Great. Welcome back to House Healthcare. We are now moving to Bi-State Association, Primary Care Association. So we've had VASN, which does the hospitals. We are moving towards primary care, specifically with federal qualified health centers, which we've talked a little bit about. So Mary Kate will bring us up to speed on what they are and what's happening with them. We're going to do some quick introductions. I am going to ask that we hold all questions because we only have 15 minutes. I'd like to make sure Mary Kate gets through her presentation. If we have time for questions, we'll take it. If not, we will absolutely have Mary Kate back. So let's just do quick introductions.
Mark Peterson, rep in Rutland District 2.
Sorry, Leslie Goldman. Wyndham 3, Rockingham, Brookline, Westminster, Bells Falls area. Sorry.
That was a good introduction. Robin McFawn, I represent Barrytown and a piece of Williamstown.
Lori Houghton, City of Essex Junction.
Alyssa Black, Essex.
Alan DeMar, Enosburg, Montgomery.
Joe Andriano, I live in Orwell, also represent Shoreham, Whiting, Sudbury, and Hubbardton.
All right. Well,
And we do have Daisy Berbecca, who represents Winooski, in the Zoom room with us.
excellent. Thank you, Madam Chair, members of the committee. My name is Mary Kate Molman. I'm the Vermont Director of Public Policy for Bi-State Primary Care Association. We represent FQHCs, federally qualified health centers, Vermont free and referral clinics, and Planned Parenthood of Northern New England in both New Hampshire and Vermont, but obviously I'm here to talk about the Vermont side. Let's see, is that moving forward? Did I kill everything on mine?
Would you like me to provide technical assistance?
I thought I had it, but should be.
Let's see, what's going on here? Did you try clicking on the slide itself and see if that helps? Okay, so there we go.
Okay, so this slide, this is where we are. This is all of our membership. But like I said, we're going to be focusing on the FQHCs because I believe you had free and referral clinics in last week.
Yes.
So as you can see, we are across the state. We are in every county. We provide services to about a third of Vermonters. These services include primary care, mental health, substance use disorder, or treatment, oral health. We are present in schools through school-based programs, which provide primary care, can be dental care, and mental health services. And we participate in the Women's Health Initiative, which I believe is getting transitioned to the Pregnancy and Tension Initiative. So we do a lot of reproductive health services. All right. So federally qualified health centers. I thought I understood what an FQHC was. I worked in the Blueprint for Health for 5 years. I was director of healthcare reform for a year. I really didn't fully wrap my brain around what an FQHC was until I came and joined Bi-State. So I recognize and appreciate sometimes this is an unknown for a lot of people. So they are safety net providers. The model was developed in the 1960s. So the model has been around and it's grown, and it was really intended as a safety net provider to make sure that there were services available to individuals where there was a scarcity of providers, scarcity of services. And as a safety net provider, FQHCs must participate in Medicaid. They must serve all individuals regardless of their ability to pay or their insurance status. And they also have to provide a sliding fee scale for individuals at or below 200% federal poverty level. And these sliding fee scales can go for uninsured. So, deducting that total fee that would be owed the health center. It can also go towards co-pays and deductibles. So especially beneficial for underinsured, and even we're seeing Medicare, having those Medicare payments help partially covered. The focus really is about integrated care. And often you'll see this list of services. They're often co-housed, co-located in the same building. So you really have the care team working together around primary care, around mental health, substance use disorder, oral health, and as I mentioned there, reproductive health. And this is, I think, becoming, not only is it really patient-centered, But it's also becoming more apparent that that's really clinically appropriate. Like we're seeing the interconnections between your mental health and your physical health. That it's clinically appropriate that we think about these two pieces and really sync it up together as healthcare. FQHCs are also really committed to their communities. By federal statute, by requirement, they have to have over 50% of their boards be patients. So there's a real focus on what are the needs of the patient and what are the needs of the community. We have a FQHC up in St. Albans and Richford. They have a grocery store in their basement. They provide secondhand clothes that people can come in and swap. So it's really like, what are the needs of the community? If there's no pharmacy, often they will open up a pharmacy. So again, making sure there is access there for the community members. In addition to these core services, there's also a real commitment to the enabling services. So transportation, translation, case management. It's really to like, how do we get our patients, how do we get our community members the best care, but also how do we address those barriers that prevent people from seeking and achieving those care? As I mentioned, we're in the schools, mental health, physical health, dental health. We have a number of clinics. North Star down in Springfield just launched their mobile clinic. So again, they're able to make that last mile and reach people who wouldn't otherwise seek care. And there's a real focus on vulnerable populations. So agricultural workers, public housing, veterans, and those experiencing homelessness. FQHCs have been key members in a lot of the healthcare reform efforts in the state. All of our health centers are members or participants of the Blueprint for Health program. They are spokes, so they provide that MAT and wraparound services. And 9 out of the 11 federally qualified health centers participate in One Care. The 2 that don't are too small. It's difficult for them to do those. All right, funding. This is often that black hole that people like get a glaze over their eyes and like, I'm out. So federally qualified health centers, according to CMS, and this is an excerpt from the Medicaid manual, and I don't want to get into the details, but basically I want to say that the intention is that Medicaid reimburse health centers at cost for the Medicaid services they provide. And I'll also say that there is, it can't just be like, we're going to charge $1,000 for this service. No, it has to be a reasonable cost as defined by Medicare. And this is extensively defined in regulations, federal statute, accountants, all of that. So again, at cost and needs to be reasonable. So the reimbursement back in 2099, it changed to an encounter cost or encounter reimbursement. This is a single payment that can cover any of the Medicaid services that have been identified for that encounter rate. In Vermont, that includes primary care, ambulatory care, and mental health services. Our dental services are covered under a different mechanism, which I'll go into. It's a reconciliation. And this encounter rate under federal statute needs to be increased at a minimum by the Medicare Economic Index inflationary factor. And this goes to the conversation I was listening to you all have yesterday with the BAA. The current status is that the Medicare encounter rates aren't coming close to what the actual costs are providing those services to Medicaid employees. We, last summer, we did an analysis of the 2021 data, and there's about a $14 million gap across all of our 11 health centers between what it costs to provide the care and the reimbursement they're receiving.
Can I just clarify, just Medicaid?
Just Medicaid, yep.
And can I just clarify? In statute, it says that they must pay 100%.
Yes, that is the Medicaid rule, and it is cost-based. They don't, in the statute, the actual BIPA statute, and trust, I'll try not to take you down that rabbit hole. It is cost-based, and then that was an excerpt from the CMS Medicaid state plan.
Okay.
We're gonna hold. I promise.
Want to follow up?
We're gonna hold. let's keep going. I promise we will come back to this. I'm already
I'm-
ahead figuring out when we.
Like what?
Hold, just
Yeah.
keep going. Thank you, Mary Kate.
I'm going to try to leave time at the end. I'm moving quickly. So this, again, this has covered what you reviewed yesterday. That increase that you saw in the Divas item 11 was last year's MEI rate. Typically, that has what Diva has been doing. They've been using the previous year's MEI to increase for the current year. We're asking the legislature to increase by the current year, and that's that BAA request. It's a technical. This is the budget adjustment. We really wanted to appreciate that the BAA is a technical kind of recalibration. We're happy to get more into the policy on reimbursement and cost-based reimbursement as we get into the actual budget bill. So that's kind of the nuts and bolts of, I saw the questions that you had yesterday. And again, I want to make sure we have some time for a few questions. The next few slides are kind of just overview of what we do and who we serve. So we serve about a third of Vermonters. You'll see that 7.2% uninsured, that works out to about 13,000 in the most recent household insurance survey. There's about 19,000 uninsured Vermonters. So we're talking about covering 2/3 of Vermont's uninsured. We also cover commercial, Medicare, and Medicaid. Funding sources, again, this is, people really want to understand where do we get our funding, because it is partially reimbursement. So the Medicaid, Medicare, commercial. Commercial will pay like any other primary care, similar to hospital and independents. And then I want to point out the pink wedge. That is our 330 grant. That is that federal funding that comes with the intention to support our sliding fee scales and other unreimbursable services. So the case management, translation, transportation, food access services. It is explicitly not intended to supplement or cover Medicaid covered services. I will also call out that FQHCs must meet strict regulatory requirements. And I do have a little show and tell. This is our compliance manual, double-sided, lots of good regs. Every 3 years, we are required to have a site visit from HRSA. This is the Health Resource Services Administration, where they make sure that we are in compliance. And this is their site visit manual. It's even thicker. Again, double-sided, and if anyone wants to look at these, you can see the level of detail that they go into and work with each of our health centers on. So with extra grant funding comes great responsibility and regulations. And that's, and then just basically what Bi-State is. It's a primary care association. There are primary care associations supporting federally qualified health centers in all of the states. And you can read this. This is sort of just fluff, not fluff, but I will call out that there's the Primary Care Association network that we are tapped into is an incredible resource for learning about how FQHCs are evolving, and especially in the healthcare reform space.
Thank you. And I will say, if you haven't had an opportunity to go to your FQHC, I highly recommend that you do. I had the opportunity to go to the Lamoille Partners. Health Partners.
Yep, Lamoille Health Partners.
And they're just one of the 11 that really do some amazing work to bridge so much together for their population. So we'll take one or two quick questions.
So my primary care is my FQHC, and it's wonderful. And I really sort of appreciate that integrated approach. But my question is regarding workforce, because at least for me and for those in my community, the main doctor who was serving our local FQHC left about a year and a half ago. And at least last time I checked, a replacement had not been found. I know they are bringing in doctors from other parts of their network, which I imagine is inefficient, also causes some continuity of care problems for patients. And so I'm wondering, is that something that's specific or special to my situation? I imagine it is not. And sort of what are you seeing with workforce, and what, in your opinion, is needed to attract more doctors and other providers to the FQHC system in Vermont?
Workforce, we're struggling. It is an immense pressure on our health centers. We talk about, the incoming funding and what we need to do, what we need to spend to recruit and retain, not keeping pace with what the reimbursement is. Competition with other organizations is we don't necessarily have the funds and resources to offer the same level of payment. I'd say it's providers, dentists. Dentists are a huge dental hygienists because you may be able to get the doctor, but you don't have the supporting staff to support the doctor. We have doctors who are rooming their own patients because they don't have the nurses or the front office staff to make sure that the patient gets in and gets set up and answers all of their pre-screening questions that normally happen. It's across the board. And training, the one-time funding is helpful, but I think it's also getting in that next generation of providers in.
Thanks.
All right, you'll have the last question.
Just so I understand, it may not be as much for you, Mary Kay, it might be for the committee or Lori. Bi-State Primary Care is an ACO?
No,
Oh,
no. They're an association.
They're what?
They're an association, just like the Vermont Area Health Hospice System, which I never get right. So they're an association, and you can answer this, that works with members. They're not an ACO.
Okay, so you don't provide the care.
we support, so you support like all of those technical systems for compliance. We do, like you can see here, data management, analytics. My role is in liaising with policy. We do have the Bi-State Recruitment Center helps bring in docs, dentists, physician assistants, and nurse practitioners. But we are also funded directly from HRSA. HRSA has identified primary care associations as the organizations to support each state's FQHCs.
Okay, so you're kind of facilitating the care, not giving the care.
We are making sure each of these organizations can operate at the highest level.
Okay, thank you.
Great, and we will make sure that we have Mary Kate back to not only talk about FQHCs, but also during the budget discussions that we'll be having to make sure we fully understand how this works very, very fast.
As part of an association, are you able to negotiate contracts with private insurers on behalf of all the members of the organization?
That is an excellent question, and we should probably offline. That is a different so we're a PCA, we do the policy side. There's also a clinically integrated network, which is similar to an ACO, but that's where you get into that contracting role.
Great. Thank you, and I'm sorry you were rushed.
No worries.
Back.
All right, thank you.
Everyone stay in their seats. We're gonna go to the next one.
All right, stop and share.
That'll be fixed.
That is,
Oh, she's gone. Is the Plainfield Health Center an FQHC? The Plainfield Health Center?
yes.
I thought it was that.
Yep.
All right.
Thank you.
Thank you all.
It's a warning.
All ready for you, Dr. Ethan. All right, so we're switching around a little bit here. So now we're going to turn to the University of Vermont Health Network, and Dr. Sunny Eapen is the new CEO of the Health Network, and he's with us today to tell us a little bit about UVM, and then hopefully we'll have some time for questions. So I believe there's quite a few overviews on our committee page, but I would think you're just talking. If you want us to reference something while you're talking, let us know.
Sure, will do. Thank you. Thanks for having me. Just for the record, I'm Sunny Eapen, President and CEO of the UVM Health Network. I was asked to just make sure that you remember the institutions that we represent in that it's CVMC in Berlin, Porter Medical Center in Middlebury, the University of Vermont Medical Center, our academic sort of medical center and hub in Burlington. That also is the community hospital. So it's the tertiary quaternary care that we provide for the entire state. and Northern New York, but also the community hospital for Chittenden and Grand Isle counties. Same thing with our home health and hospice. It serves Chittenden and Grand Isle counties. And then in New York State, we have CBPH in Plattsburgh, Alice Hyde Medical Center in Malone, and Elizabethtown Hospital, which also pulls in Ticonderoga, which used to be a hospital that's been converted now to a 24-hour emergency access center. And then we move patients from there as needed to the right place. So I was going to just briefly tell you about myself, quick introduction. I feel like people have heard pieces of it, and some
were not there this morning. So please do your normal.
Great. So born and raised in Chicago. Dad was a pediatrician. Mom stayed at home. I have a sister who's an accountant, also in Chicago. Immigrant, solo practice pediatrician, if you know that world. It was, I can't remember a single night at home where he didn't get a phone call. Sometimes he'd go into the emergency room because you had to if you sent your patients in, you'd have to accompany them there because there was no doctors in the emergency room. You were the doctor there. It was just a place. I was pretty convinced that that is not the life that I wanted. It was way too hard work. And so I sort of headed off in a completely different direction. My degrees in math and computer science from the University of Illinois in Champaign-Urbana. And quite late in that college career there, I decided, maybe medicine won't be bad. And I sort of did the MCATs and took the prereqs, and I wound up going to medical school at the University of Chicago. And I met my wife when I was a freshman. I was 17 years old at college, and she wound up going to medical school as well at the University of Illinois. And we both came out to Boston with the idea that it'd be good for us to have a little autonomy from our families. She's one of 7 kids. I have just that sister, but quite an extended family. And so we thought it'd be good for us to get away for 3 to 5 years and then come back home. 30 years later, 3 kids, and now I'm in Burlington. So, but I had a great, I would say, sort of academic path in Boston. I did my training in anesthesiology at the Brigham and Women's Hospital. I sort of spent the next 3-4 years in a basic science lab, thought that's what I wanted to do, and then realized that wasn't the right thing for me. In the middle of that, I had a child who died. And so that sort of shifted our goals at home. And I wound up staying at home, job sharing with my wife for about 6 years, where I worked 3 days a week. She worked 2 days a week. And that really sort of shifted our perspective on life and what we wanted to do. And also about thinking about, I was part of the part-time committee at the Brigham, which was me and at that time, me and like 29 women, and just had us great perspective on what it meant to be a physician, a mom, had to take care of all the responsibilities that society and they themselves put on them. So it sort of shaped the way that I think about those and my leadership style, which is very servant leader sort of methodology, where my job is to make everyone around me succeed. And that's how I succeed in creating safety around conversations. And so that's what I'm hoping to bring here is much, I think, I don't want to say more, but a very transparent culture where people really share their ideas openly and they're not fearful about that. And so that's where we're headed. That was me. I'm happy to answer any questions about that. Just a couple of things to maybe emphasize to you where we stand. We are a not-for-profit health system, and that really means something to us in the way that we think about our roles. And that is clearly evident as I've traveled across the state and in Northern New York, where folks really feel like they need to serve their communities. The people that work there, the institutions themselves, are committed to that. And that's really evident. Our providers really, really care deeply about the work that they do and how they serve their patients. And it pains them when we can't do the very best that we can. And then the reality of our financial situation. We lost $90 million last year. First quarter of this year, the results are back, and we're heading in a path that we're going to lose even more if we keep going down that path. So we've really got to sort of take the bull by the horns and change some things about the way that we're doing them, which has consequences to the care that we deliver. So we're being very deliberate and careful about what we need to do. It's not any better in New York. I would say it's actually worse for our hospitals there and the hospitals in general. And we're working really hard with the state there to help, because quite frankly, they're just distressed at this point in a worse condition than we are. And we really need to help just to keep the doors open there because that's that dire. But here we are. I look forward to working with all of you to do the work that we need to do, which I am really positive about. I want to end on that more positive note. I'm really positive about the work that all of you have already done to set up the state in the way that it is set up, which is that we really care about every single resident who lives here. We care about making sure that there's equity in the healthcare that we deliver, and that our residents, our citizens here really care about that. And that is an enormous advantage that all of us have in the way that we can deliver care that many states in our country do not have. And so it's really, I feel the responsibility, I'm sure that you feel, that we have to deliver on that promise, which is how do we deliver great care to our residents and what do we need to do to do that? And for me, that means that we need to make a margin so that we can reinvest in our physical structures and reinvest in the people that work at our institutions so that we can serve. Those are the stockholders that we have. So I'm happy to go in any direction. If I don't know the answer, I'll say I don't know the answer.
We do that very well. So
I've been here for 6 weeks. I think this is my 7th week, so it's early on in the process. But I feel like I've been here for much longer.
Vermont does that too. I will open it up for questions. I just want to make one statement as a representative from Chittenden County. I think something you said in the beginning is really important. We think in the state of University of Vermont Health Network as an academic medical center. In Chittenden County, it is our community hospital. And so, every Copley, all the other places that are, considered more community hospitals, you're ours. And I think that's really important for people throughout the state to remember when we look at University of Vermont Medical Center. So, Brian, you had a question?
Yeah, I have one question. I mean, there'll be more, but since it was called on, I was going to make a list. I asked you some earlier today, so I'm not going to ask you again, even though it might be good to ask you again and get it on the record so that people can hear the answers to those questions. But the one I have now that I didn't ask earlier is where are the greatest areas of loss? Like you talk about the profit margin, like where is when you look at the numbers, are there any glaring losses?
Yeah, the one that's really easy and obvious is our travelers. If we could eliminate travelers and overtime, we would essentially eliminate the deficit. Not perfect, but essentially eliminate it. It's really, really big. And of course, the balance, right? The challenge there is that we know that if we just completely eliminate it, then we're not providing essential care that we need to do. And so the balance is how do we pick the areas carefully that we have to continue, and how do we pick the areas that we have to slow down and kind of squeeze a little bit more and be even more innovative about? And that's hard. It's hard if you're working in that area and you're dealing with the patient, but we're thinking broader than that and longer term than that, right? Because it's like the one patient that we turn down or don't turn down today, my fear is it becomes 3 if we're not sustainable down the road. So we're thinking on the longer term. That's the biggest. Then there's the inflationary pressures, which really have affected us on just buying devices, buying materials on the supply chain is significantly more expensive. Pharmaceuticals continue to be a challenge, and that goes up every year, 5 to 6%. It's probably gone up 10 to 15%. But if I could choose one of them, it would be the obvious one.
Joe, and then Leslie.
Yeah, so I have 2 questions. One is specific, the other is general. So yesterday and over the past week or so on this committee, we've been discussing the Budget Adjustment Act, and part of that has been these 9 beds that we suggested that approximately $9 million be approved for a feasibility study down in Bennington for inpatient youth psychiatric med beds. And in our committee, there was a lot of discussion around the fact that, we have Brattleboro Retreat in southern Vermont already. This would be in Bennington. And there's a lack of these sorts of beds in the northern part of the state, in particular Chittenden County, which is obviously a populated area. And part of our discussion around that ended up being, sort of this hope that, while we wanted to recommend this project because, we need beds, there was this hope that we have that, it might come to pass that, we could also get beds, up in the northern part of the state in Chittenden County and Burlington. So my first question is basically, is that something that's anywhere in your medium or long-term plan that might be doable? And what are the barriers to that happening?
Yeah, so two sort of, I will say, just principles. One is that, and maybe contradictory to what you might think, is that I think beds anywhere are valuable for that population. And so I'd be an advocate. And if you're a family member and you have a child and you have to drive 2 hours to take your child to that place, if you can find the right place for your child, you'd happily do that, is my feeling. And so I don't think that should be, we shouldn't think about that. If there's an opportunity to do that there, I'd be an advocate. And if we could help with expertise or however we could help from our organization, we should do it. That's one. On the very specific piece, we've been really, as I understand it, really trying hard to explore how we bring in mental health beds in general, adult and pediatric. And there's all sorts of challenges, but the financial challenges are really big. That doesn't mean they're not a part of our planning and that we would, we're looking at what our needs are and we are going to put them in there. And then we have to figure out how to pay for them. And we'd probably come to you and say, here's our plan. How can you help us to do this? Because the gap between what it cost us and what we get is pretty significant. Right? And that's the challenge, just sort of very coarsely. Yeah.
Thank you. And my second question is related to the question I asked during the reception this morning. I'm going to ask just a little bit differently. We've heard so many stories about, boarders in emergency rooms or folks not having a place to be discharged to, or, so many stories I'm not going to count them all here. I'm sure you know them far, far better than I do. And what I'm thinking about is, are there any short-term fixes to this problem that you see that we can help you with? I've heard about long-term fixes and medium-term fixes, but I'm wondering about, is there anything that could alleviate the strain and the pressure we're seeing on patients, on providers? A thing I've been thinking a lot about lately is like provider care is patient care, because providers need to be well for patients to be well. So is there any way we can help in alleviating that stress on our providers and on the system as a whole to help patients?
Yeah. So the short-term solution, and we're trying to do it, but is that if we have post-acute beds anywhere in the system, they should be opened and we should staff them, because at any given time, our hospitals have a significant number of patients that don't need hospital care, but they have no place to go. And so the first thing, and then we're doing this internally, we're saying, yes, travelers are really expensive. But we need to, that's how we're going to prioritize as a way, is that we're going to open every nursing home bed, every post-acute bed that we can with travelers, even though they're expensive, because we've got to move that shift that out as we're doing everything else. So anything you can do to help, and simple things would be, again, paying the difference between what it would cost us otherwise and what we have to pay travelers. As an example, even if it's a short-term, that's an immediate short-term gain. I would say the same thing with behavioral health beds. If we have behavioral health physical beds that are around that we can open, that would be mental health beds. I'm changing my dichotomy on that.
Thank you.
I've forever, it was ingrained in me to call them behavioral health bed because of the stigma associated with mental health. And I don't have that stigma, but I'm changing my lexicon. For the mental health beds, that we should, if we have them physically available and we can open them by paying more to staff them, it would be fantastic to be able to do it, and you could help with that. There's no doubt in providing, again, even if it's a short-term funding, short-term, a year funding to stabilize, that would be amazing if we could get that. The psychiatric nurses are particularly difficult to get, even if you're willing to pay, but it helps if we can raise the numbers on that. That would be helpful. The gratitude piece, again, gratitude to our caregivers. It means a lot that they feel appreciated. Sometimes I think they feel a little bit forgotten when they're there. And so part of the work that all of us can do is, they're your neighbors, friends, relatives, and come visit and say thank you. It goes a long way. You'd be surprised at what an impact that has to be able to be recognized. But it really does make a difference to people that are doing the work. So.
I'm going to jump in and ask a question, and then we'll go to Leslie and Mari. So we've talked about costs and the financial situation we're facing here in Vermont, and we have a very different regulatory structure than I think where you came from. Correct me if I'm wrong. And so I'm curious about your thoughts about the Green Mountain Care Board and that regulatory structure we have here in Vermont. And then, tying that in, you've mentioned margin, what does that give us a real clear example of, our margins are point something that's preventing us from doing X, Y, and Z? I think that would be helpful to understand.
Great. So the regulatory piece, so Green Mountain Care Board, just philosophically, I think regulators are good for the work that we do, particularly not-for-profit and for-profit healthcare, because I think they make us honest, transparent as possible, and hold us accountable to the work that we're supposed to do. So I actually think that, again, maybe a little bit contradictory, maybe contradictory to what the University of Vermont Health Network might think, but I think it's a positive thing. But on the other side of that, what you need on the regulatory side is people that are incredibly knowledgeable and understand the industry that they're regulating. I think that if you don't have that, then it's a real challenge to get the work done, because it isn't evident, and it's, the finances are complicated. Healthcare is complicated. Power is complicated. Electricity is complicated. If you don't understand the industry, it's hard to regulate it. So you really need to have people that are aligned, because philosophically, we're all on the same page. That is, that we all care about how do we keep our patients, constituents, residents healthy, and how do we take care of them when we're sick, do that really efficiently. And so we're all aligned on that, but if we don't understand each other, I think the challenge there is to try not to be political in the decision making. So I would say that in Massachusetts, the Health Policy Commission, which is sort of a advisory to the government as opposed to decision making, is incredibly knowledgeable, and they really understand healthcare and they understand public health. The challenge there is to remain apolitical in your decision making, and there was lots of politics that interfered with that, but they were knowledgeable, and there could be a model for what we need to do. And that doesn't mean that the patient's voice or the citizen's voice doesn't get represented. You're going to kill me, but I forgot this.
An example on the margin. So what are your margins, and how does that affect the decisions you're making on being able to invest in youth psychiatric beds?
Yeah, so there are probably, I sort of think of the margin of what we do in two big, bold, broad ways. One is the physical plant and structure of what we need to do. And those include things like, our existing structures, like our hospitals and emergency rooms, that if you walk around to all of our emergency rooms, they literally are falling apart and being held up in ways that they really shouldn't be. And so the way that and the elevators are breaking down, and then we pay extra money, the way that the margin helps for that, right, is that we build in that the ongoing kind of maintenance capital, sort of refurbishing, comes from that margin. And so what happens when we don't have a margin is that reinvestment into just maintaining the plant that we build into that margin is gone. And so we prolong everything from, I'm just trying to think of the stories that I heard yesterday, the orthopedic surgeon and the arthroscopic equipment that they're doing. They are looking on eBay to find equipment because it's been obsolete, and we're just bringing those pieces together, right? Those are the kinds of things you do when you don't have a margin. The other part is again, on just the capital portion, is like, MRI and CT scan technology is changing and becoming better and faster, and you don't invest in those things because we plan and take that margin to put it back into that so that we can update the equipment. But the really important part of the margin is the reinvestment in the people. And the reinvestment in the people is partly creating the pleasant environment where they know that they come into work and the elevator isn't broken, or all of those pieces. But actually the reinvestment and how much we pay people comes from that margin to be able to invest in that, right? In a way that is really, really important if we want to stay competitive. And what's happened in Vermont is that we've gone from sort of a regional area that we had to compete for folks that we have to compete nationally now. And that has, more than the inflationary pressure, it's boosted us like a significant amount to be able to compete for the physicians, nurses, everyone, because it's a national marketplace. So that margin makes a difference. So last year we had a negative margin, right? When we lose money, we have negative margin, which means that all of those sort of normal kinds of things that we would otherwise reinvest in comes to a halt, essentially. And that's why it becomes really important. I'm going to separate that out from some of the capital things that so we're sort of dealing with the here and now in real time, but then we're also thinking ahead 15, 20, 30 years, right? And so when we think about what do we need to invest in today as we look ahead to our growing population, what do we need to invest in because our operating rooms at the University of Vermont are truly are falling apart. The air handling systems are not up to par where we would want to be, and we're sort of fixing it. So we're also thinking about the next 20 to 30 years, and that's sort of a different piece. And we try to make sure that when we do that, that's self-sustaining in a way, because we can't count on the margin to continue to fund that. And so that's where you would make decisions like, we need to go for ambulatory surgery center, and we can't afford to go for the mental health hospital that we would want to have, as an example, right? Because we have to stand, those things that wind up having to stand independently as opposed to being able to be fed from the margin.
Yesterday in this committee, we had to prioritize two budget adjustment requests we were putting in. It was very difficult to choose between those two things. We had a pretty extensive conversation. I can't imagine what it is like being at a hospital having to choose between those types of things to provide care to Vermonters. Leslie and then Mari, and then we'll probably have to close up.
So I have two unrelated questions. First, we just heard about Medicare Advantage, and UVM has sort of developed a Medicare Advantage product, and I'm wondering how that fits into your business model.
So it's a great question. There's two pieces to that, of course, or maybe more. But so the Medicare Advantage plans that we're partnering with MVP to fit into and work on together has never been able to make money to stand alone yet. So the business plan for it is that we hope that we can do some really innovative things so that we get to a point that it's actually self-sustaining. That's the one. But more importantly, the reason that we want to get into it and work on that is because it fits into our fundamental philosophy of what we think about on a value-based care population health way of taking care of patients instead of a fee-for-service model. And so it allows us to get into that marketplace in the Medicare patient population so that we can do and provide the wraparound services to keep people healthy out of the hospital. And then when they do come in the hospital, when they get out, how do we set them up so that they stay out? It isn't what you may have heard on the news around Medicare Advantage plans, because we're not a for-profit model of what we do. If there is a margin that gets generated in that, it simply goes right back in to create the wraparound services and expand that. That's what we want to do for our entire population, right? So building the infrastructure in every way that we can, whether it's Medicaid patients, Medicare patients, and for everyone, it goes along with our overall, all of our collective overall philosophy of how we want to take care of patients. And so does that answer your question?
If I may,
Please.
how does it differ from like regular Medicare? How does that help you in a way that whole other model didn't?
Yeah. So regular Medicare, even though today it sort of falls into an accountable care model, the reality is that at the end of the year, we actually reconcile on a fee-for-service basis, and you still get paid based on that way of doing it. So we wind up keeping like literally two sets of books around, we're getting the per patient per month, which is great, but then we have to actually track what we're actually making. The idea here is that you can actually provide more services by putting these wraparound services around the patients to keep them out of the hospital, keep them healthier. That it allows us, the clear example is dental care. Like Medicare doesn't cover dental care, but our Medicare Advantage plan would cover dental care. Specifically for us, and what we're trying to create as a differentiator is that the product is connected very much to our clinicians, where our clinicians, our primary care docs are saying, and primary care caregivers, nurses are saying, here's what our patients need, and this would actually help them, and it would keep them out of our hospital. And so we're trying to build those into the product itself, and then connecting. We've done it initially, the product, as we go, connecting with the patients to say, what do you need? So we're connecting both what the caregivers are seeing and what the patients are seeing, and trying to deliver on that end. That's the differentiating idea of what we're trying to do with MVP on that. Does that make sense? And there's nothing nefarious. There's nothing like that that's coming back. It's not, I don't want to name.
Of course, in the great about that, down the line, people don't get what they need. So there brings up worries, and I don't know if you want to continue this, but and I know.
Yeah, but if you look at, like, if you have someone, a relative, like my parents are, and I encourage them to get into the Medicare Advantage product. From a patient point of view, there is no doubt that what they get is better. And so, how do we do that in a way that's truly beneficial for everyone involved? We're not trying to make We're not trying to make a profit out of it. We're trying to put that back in and deliver the better service, right? So.
Thank you.
Sorry?
Thank you, Dr. Eppen. You may have been warned ahead of time, but you're my boss.
No, Mari, I think the only thing I know is that I know that you did a lot of work on the infection control on line placement, right? Line work. So I did remember that. So thanks for the work that you do.
Thank you. Yeah. Also did a lot of work last year with a great group of people on pharmacy benefit management, but that's not my question right now. As a frontline nurse for, I don't know how long, I think 34, 35 years, most of it at UVM Medical Center. I love working there. I'm currently in inpatient cardiology. My colleagues, even pre-pandemic, colleagues across the country have said regularly that the healthcare system, the funding of the healthcare system as a whole has chronically undervalued nursing and other parts of the workforce. And then come the pandemic, and I don't like these words. I think there's better ones, but many of us, most of us are tired, burned out. And I think, so I'm interested in hearing, knowing that labor is the biggest or one of the biggest line items in a hospital budget. Staff feel financially undervalued systemically nationwide, so I'm not pointing fingers. We definitely made progress over the last couple of years, and that's been helpful. We also have the graying of the workforce. We know that we're losing employees to retirement, so it just seems like an insurmountable problem. So when you're talking about cutting back on traveling staff, and I know you agree with me that when I work alongside travel staff, I'm really grateful they're there because it means we have enough skilled help to help us with the patient care that we love so much. So how do you do that? You know, when both lift up staff who've been undervalued for so long, but then reduce the use of travel contract staff.
That's the question. How do you do that, right? If I could figure that out. But here's the way we're thinking about it, Mari, and it's really hard. So first thing I would say is that, you know, I'm an OB anesthesiologist, and if you've ever worked on the labor and delivery floor, like the relationship that I have with the nurses that we work with are essential to the care that we deliver. So I completely value the work in every way that you can look at that. When you talk about burnout, whenever I talk about burnout of physicians, I talk about burnout of nurses in that same breath because it's the same challenges that we have. You point out one piece of the traveling nurses or travelers in general, however you want to look at it, per diem employees on the physician side as well. It's the same thing, is that they really help us because they help us to provide really critical care that we need to help, right? And we need to deliver. There's a demoralizing part to that when you're feeling like you're not feeling valued enough as it is. And the person that's sitting next to me who doesn't have as much experience as I have, doesn't know the place as well as I do, I'm helping them and they're making twice as much money as I have at every level. So that's also a thorn in our side that we have also heard and felt, and I'm sure you've seen. That's not the way that people come in. They're just doing their job, and the vast majority of them, as you know, care, right? They care about the work that they're doing and care about the patients in front of them. But that's a real issue. And so we're balancing both of those. And so the way that we're trying to do that is trying to be very careful about where are we going to very slowly and deliberately so that the burden of doing more work doesn't fall on the existing staff. So we're being very deliberate at how we're choosing that. And at the same time, we're trying to expand that home health and hospice part and the nursing home part, right? Because we know we've got to move patients off in order to constrict the care that we deliver there. Our goal is that for our existing workforce, that it doesn't make things worse while we do that. And we're going to do it slowly and deliberately, reassess as we go along and try to answer that as we go along. But you let us know if you see something different. And that's going to be,
I do want to be clear that, and that's why I used funding systemic nationwide. I do feel very valued as a nurse and have on every unit I've worked at in the hospital. And I know most of my colleagues would say the same. And we love our relationships with providers.
Thank you. So unfortunately, I know we have testimony and I know you have to go give more testimony. So we're going to have to call it a day. We really appreciate you taking the time. On behalf of the committee, please continue to thank your staff from us. We know it's really hard for them right now.
thank you very much. Thank you for the time. I really appreciate it.
All right, we are going to stay in our seats and invite Health First to come up, which you can, there is another chair right there. That representative is not coming. If you want to join, if you don't, that's fine.
Could someone throw me those tissues?
These
Or pass for me to throw? I have a high deductible. I don't want to get it in the eye.
need more tissues in this place. Thank you for understanding. We run a couple minutes late, unfortunately, as much as we try. So we are turning back to primary care and learning from another important group within our state that offers primary care services. So you were here for introductions of the committee, right?
Yes.
So we're going to skip that and go right to your presentation. And do you have anything to share or?
I did share with Claire the
Okay.
presentation.
So it'll just be online when you want to look at it and we'll listen
Yep.
to your testimony.
So I know I stand in the way of your lunch break, so I will get right into it. My name's Susan Rinson. I'm the Executive Director of Vermont Health First. I'm joined today by Rick Dooley. He's our Clinical Network Director and a great resource. He's also a physician assistant at Thomas Chittenden Health Center, which is one of our independent practices. So Health First is an independent practice association. We've been around since 2010, and our only mission is to support and promote the long-term success of independent practices. So those are practices owned by physicians. We have 63 practices in our network across the state. If you look at slide 2, you'll see that the split of primary care to specialty care practices is 42 to 58%. For a long time, we were at around 50-50, but we have lost a number of primary care practices over the last few years. So we're seeing that skewed. I won't go through it, but you see we have physicians are our members. We also have advanced practice professionals like PAs and MPs in our network who are working in our practices. We are located in 10 counties throughout Vermont. We have, as you might expect, because of the population base, we have a concentration in the Chittenden County area with 61% of our practices there, but we do still have practices outside of Chittenden County. And our practices are not just primary care. We also have, as we figured out, specialty practices representing over 30 specialties. So I do want to kind of drill down to primary care, though, because as you all are aware and have worked to support, primary care is the foundation of our healthcare system and really the way we're going to get a handle on costs. Our 26 primary care practices, we estimate care for over 85,000 patients. Of the 11 primary care practices in Chittenden County, we estimate that they're taking care of about a third of the Chittenden County population. The rest of them are outside of Chittenden County and care for almost 40,000 patients. The other thing I just want to point out is that 15 of our primary care practices are one care participants. 7 of them are in the comprehensive payment reform program, which is the capitation program. You might be asking, well, why are only 15 of your 26 practices participating? But if you look at it, all our larger and medium practices are participating, and they collectively represent 94% of the 85,000 primary care patients that are cared for in our practices. It's really the very small practices, concierge practices who don't tend to accept insurance and that sort of thing, who are not participating.
Thank you for that explanation. That was
So on the next slide, I alluded to the fact that we have had a decrease in the number of primary care practices. We've seen a decrease in the overall number of independent practices in our network. And just as an aside, we do estimate that we have roughly 85 to 90% of all the independent practices are Health First members. So what we're seeing in our network, you can extrapolate. And this trend is not unique to Vermont. It's something that's happening across the nation. But the decline is steeper amongst the loss of primary care practices. The reasons for the decline are many. Probably the biggest reason is the inability, the financial insolvency. These practices are going out of business because they're just not getting reimbursed at the level they need. You've heard this from everybody. It's especially true in the independent practices. I'll talk about more about that in a moment. But that's a big reason why we're losing practices. We also see a number of physicians retiring. And they're just not being replaced. You have students coming out of med school with lots of debt, and that they're not in a position to go into independent practice, unfortunately. So why do we care? So the independent practices are going away. Why do we care? Well, it's really important to have these practices in our network. They are the value that we're looking for in our system. They consistently provide very high quality care for less cost. So that's value right there. The experience of care at a community independent practice is just different. It's a more personal relationship. Typically, they're smaller practices. Patients are typically see the same provider more frequently than they might in a larger system. They're just more nimble, so they're able to respond more dynamically to the needs of their patients, don't have to go through bureaucracy. There's not a big scheduling systems and things like that. And that personal relationship that a patient, that an independent practice fosters, that they can have with their clinician, helps them stay healthy and well. And there's some good evidence to that effect. Patients want options for care. There certainly are patients who want to go to an FQHC or a hospital system, and those options should remain there, but so should the option to go to an independent practice. People will want to go to that practice that's part of their community. They know the staff who work there and the physicians, their neighbor or what have you. So it's important to maintain that. Not only is that choice important for patients, it's also good for healthcare providers. And as we are competing to bring in healthcare providers into Vermont, when they have those options, if there's a viable independent practice network, they are, that option is there for them to work. And, a lot of times we'll see a couple married where there's two physicians or, two nurses or a physician and a nurse. One of them wants to work at the hospital. They're in a specialty that makes sense to be in the hospital, but the other one might want to, open their own practice. And so it's nice to have those options. And last, but certainly not least, having a strong independent network helps to diversify our healthcare system. So, and it just provides more resiliency to the overall system. And we saw this play out. We had a global pandemic. We had a cyber attack at UVMMC that really stymied the hospital for a while. But we still had the independent Green Mountain Surgery Center and the independent practices who could see their patients and provide that net of care because we have different options. So I wanted to share with you a patient story because it all comes down to the patient. This is a story told to me by Dr. Jenny Lowell, who's an OBGYN at Matry, and pediatrician Dr. Jennifer Carlson, who's at Pediatric Medicine. And forgive me, but I'm going to read it so I don't forget some of the details here. But to me, this story demonstrates the nimbleness and the patient-centered care that is possible in an independent practitioner. So this patient was a teenager who suffered a complicated hematoma in her groin while at a high-level ballet program in Europe. So she was hospitalized abroad for 3 days and then sent home on a transatlantic flight to follow up with her physician. So the family called Dr. Carlson's office, and the patient was seen within 24 hours of stepping off the plane. She was put in an end-of-day appointment on a Wednesday scheduled as follow-up hospitalization. So when Dr. Carlson heard the patient's story and performed an exam, she realized that this teenager had a very complicated gynecologic issue and that she needed urgent evaluation and likely surgery. So Dr. Carlson gets on the phone with Dr. Lowell, the OBGYN. Dr. Lowell happened to be driving in her car, coming back from being out of town, but said, I can see her tomorrow at 8 a.m. Before my usual clinic start time at 8:30. So Dr. Lowell calls the back office staff to have them set up a patient account to get that patient in the next day. As an aside, I'll say that, well, actually, let me stick with my notes. That would be better. So when Dr. Lowell saw the patient on Thursday morning, she immediately knew she needed urgent surgical intervention and scheduled her for a time slot at the Green Mountain Surgery Center. Dr. Lowell was scheduled to be in clinic at that time. So what she did is she basically saw all those patients over her lunch hour so she could be free during surgery time. Note that because the patient's issue had been going on for so long, the physicians didn't feel the situation was emergent, but it was certainly urgent. They felt that the ED would best be avoided. As we all know, the ED is very overburdened. But they also were thinking about the patient and that they thought it would be a traumatic experience for her to be in a curtain room, having a non-GYN clinician examining her before a GYN consult came in. So, they chose to avoid that as they could. So then when the patient arrived at the Green Mountain Surgery Center, they were able to do IV sedation instead of intubation. They were right-sizing the care there. And then Dr. Lowell also texted the OBGYN resident that was on rotation so that she would not miss out on the opportunity to do the training, just to make the point that training is going on in the independent physician network. So the case went well, fortunately, and by Friday afternoon, a mere 48 hours after the patient saw the pediatrician for the first time, this young woman was post-op at home and much more comfortable. On Saturday, when Dr. Lowell was on call, the one who performed the surgery, the family paged wanting to ask a few questions. Well, of course, Dr. Lowell was very familiar with the case, which is much less likely to happen if this all happened in a health system where there's a much bigger call and so forth. But the family was basically wondering when the patient could go back to their out-of-state dance specialty school. So Dr. Lowell worked the patient into her schedule on Thursday to assess her healing to make a plan to go back to school. So Dr. Lowell saw the patient on that Thursday, saw that the woman was already markedly improved, so the woman returned to school. So this patient and her family were so thankful for the really responsive and personal care that she was able to get, how quickly she was able to get in to see a specialist in surgery. And I think just perfectly demonstrates the nimbleness and the accessibility that the independent network provides to patients. And that is something worth preserving and fighting for.
Thank you. Good way to describe that.
All right. So hopefully I've been able to convey that, the value of our independent practice network. Now I want to talk about the top barrier to our independent practice network. And it's no different than what Mary Kay talked about and Dr. Eppen. But I think it is more acute for independents because of the way they are paid. But the top barrier are reimbursements that don't keep pace with expenses. Independent practices face the same challenges with workforce, supplies. There's also, people don't think about this, but these practices are also small businesses. So when the Green Mountain Care Board approves a rate increase for the health insurance companies, right? These practices buy their health insurance off the exchange, and they're looking at ever increasing rates to insure their employees. But the payers aren't increasing it on the other side. So what you have is basically a recipe for going out of business. And it's not a matter of if practices will continue to go out of business, it's a matter of when. And I will contend that our primary care and also women's health practices are our most vulnerable and need of support. This slide here, I think, demonstrates the difference on how we're paid. Like Mary Kate puts up her little pie chart, and you see different revenue sources for an FQHC. The hospitals have facility fees. The academic medical center, in addition to facility fees and professional fees, they have 340Bs. They have medical education payments. The independents are their only revenue source is what they're being paid by payers. And when they have basically no negotiating power, the money is not coming to them. And that's a real problem because it's not enough to sustain these practices, sadly. So that's what needs to be corrected. How you can help, you can support legislation that aims to provide independents with fair and sustainable reimbursement. Narrow that gap. People don't realize there's a huge gap between for professional fees only. This is not even including facility fees, but a cardiac, say for example, you're out to dinner, you have some chest pain, you end up at UVMMC, right? Depending on your insurance and the cardiologist that's on call, if it's an independent cardiologist versus a hospital employed cardiologist, you could pay $800 more for a cardiac cath if you happen to be there on a night that a hospital employed cardiologist is. And that it's the same service. So it's a real problem, and it's stymieing the viability of our practices. The other thing that you can continue to do that you've been great about is supporting primary care. And I have that add-on women's health. So preserving Medicaid payments at 100% of Medicare is helpful, although you may have heard there's been cuts to Medicare for 2023. So we are advocating that we stick with the 2022 rates and ideally build in some inflationary adjustments there. That is something that would help. As well as just increasing overall payment spending or primary care spending. Some of that work has been achieved through the redirection of funds through the OneCare programs. That has been helpful for sure. We need to keep moving in that direction. A lot of talk about workforce. That is definitely a challenge for our practices as well. Continuing to fund the primary care loan repayments and scholarships is hugely helpful, and the workforce retention and recruitment funds that is coming, that will be helpful as well. We always hear about administrative burden. That's a huge issue. Working, some of the work with Act 40 will help some, although it's still a pretty onerous issue that needs more attention, but that's a step in the right direction. And the other sort of big thing is just help make Vermont more attractive to independent providers. We have some of the nation's most restrictive certificate of need laws, and that discourages people, clinicians, from wanting to set up shop here. So that would help, and it would provide more options for patients as well. And I would just ask you all, as you're, looking at policies in the system, consider the impact on independence, and answer any questions or, get in touch, and we can, let you know, help you out.
Thank you. That was very helpful to understand the role, the large role independent practices play in Vermont. So we'll open up for questions. Art?
Yeah, and you understand it, and I'm confused.
I confuse you.
Well, you know what you're doing. I don't, and I'm trying to understand when you say independent. What does that mean? This is my third year in healthcare, and I made a chart here that tries to help me understand how all this fits together. What do you mean by independent? And how do I know as a patient whether I have an independent provider?
Good questions. It's not easy to know, especially you go online and a lot of the independents will say they're affiliated with the hospital. But what it means is the practice is owned by the physician. Their name is on the shingle. There's not an administrative staff telling them how to practice medicine. It's them making the decisions, them keeping the business viable.
Okay.
Yeah.
Are they a part of OneCare?
So we have a number of practices who are participating in OneCare.
But they don't have to?
They don't have to.
No one has to participate in OneCare.
No one has to.
No one has to participate in OneCare. It is a voluntary system.
Wait a second. What if your doctor's in OneCare, then you have to be in OneCare?
As a patient, if your doctor is in OneCare, yes, then you're a part of OneCare too. But a practice, no healthcare practice, has to participate in OneCare.
If I inject, for any patient can opt out of
Yes,
belong to
as well.
ACO. So if your doctor's participating in OneCare, you can sign a form that says, I don't want any of my information to go to OneCare, and you won't be counted as an attributed.
So
Thank you, Vic.
Yeah.
Oh, I'm sorry. I'm Rick Dooley. I'm the clinical network director and a family practice PA in Williston.
Family practice PA.
Yeah.
Thank you for clarifying that.
Yes, thank you.
Yep.
All right, does that help you?
Well, it helps, but now I'm equally confused. Okay,
Please help more.
so an independent physician gets the payers pay him, and that's it, right? And he provides service. So he bypasses the OneCare, the ACO.
Can I give you an example?
Sure, I'd love it.
Personal situation.
Please.
So my primary care provider and my husband's primary care provider is part of the UVM health network, right? So when I go and see my primary care provider, they are actually part of University of Vermont Medical Center.
You're employed.
They're employed by University of Vermont Medical
All
Center.
right, okay.
When my son goes to his pediatrician, those doctors have an independent practice. They are not connected to the University of Vermont Medical Center.
Okay.
As a nurse, the people who pay their bill is the owner of the practice. It is not University of Vermont Medical Center.
Okay,
Does that help?
it helps. Afterwards,
We can talk some more.
I can
Guys,
add
come
to
over
that
and look at
story
this.
too, because I have a personal experience.
So we'll do that offline.
Yep.
Okay, Joe?
I could add to that story too, but I'll do so offline. First of all, I want to say that your slide about from 2001 to 2021 is sort of the clearest I've ever seen anyone put this point, and I really appreciate that because that.
Which slide?
It is slide 8, top errors, and sort of that practice cost versus pay. That was very helpful in framing some of this. But my question is regards to on slide 11. You mentioned this idea of a gold card program, and I had a question for MVP Healthcare earlier this morning about prior auths. And so I'd never heard of this gold card thing. I was wondering if you could expand on it.
It's sort of a generic term to say that you have a special privilege, so to speak, to not have to do either as onerous of a prior approval process, or you actually can skip that process to be able to get a test for your patient.
And so would this be a physician has a certain standing with an insurance company? The insurance company basically says, you have this seal of approval that you're just so good at this that we don't have to go through the same rigmarole every single time. Is that?
Yeah, exactly. When they did the pilot program, it was based on your number of declined referrals. So if you did, if you were scored at a 95% or higher of your referrals automatically going through and getting approved, then you got the gold card. Said we're not going to check every single one for you. That's the premise.
Okay, and so I guess my question is, you recommend in your slides that we have payers expand that. So, and you mentioned Texas. So is there a law in Texas that says insurance companies have to have a gold card program? What's
It's a good question. I'm not certain that it's a law. I'd have to get back with you on the details on that. The point that I wanted to make with it was more the threshold A lot of times the threshold is 95, 98, whereas this particular program was lower, so more permissive, which I thought would be a help.
Yeah, I would appreciate if you get more information on that.
Yeah.
I would appreciate it, thank you.
I'm sure everyone knows, the vast majority of prior authorizations, even in dials, end up getting approved once I get on the phone with the provider. And they're almost nothing more than a barrier to care, just to try to, weed out those who aren't willing to put forth the effort. But I will say that I can probably count on one hand the number of times that when I do a peer-to-peer review on denial, and I say, here's why they need it, literally one hand in 25 years where they've said, no, that's not the right study, you need to do this, or no, that's not the right provider, you need to do this. They get approved, they just require extensive amounts of work to get there, time and energy and effort.
Hours on the phone.
And I've talked to.
Respective months.
Absolutely, absolutely.
And I've talked to a couple of doctors and nurses, I'm sure you all have as well, that, they often do it in the evening, so they see patients all day, they come home. One doctor said to me, I see patients all day, I come home, I spend time with my kids, I feed them dinner, I put them to bed. I get back on my computer for 2 hours to work through these situations.
There's not a primary care provider who doesn't do that. I mean, I see patients from 4:30 typically. When my kids were young, I would go home and have dinner. Now my wife and I are empty nesters, so I just say, okay, I'm going to stay and work until I finish, and typically I'm there till 7. And then a Wednesday when I have my day off, or the weekend, is when I get caught up for all the other administrative stuff that I get a chance to do between 8 and 7. So it's a busy job.
Providers are exhausted.
Yeah.
Yeah. As you've heard.
Yeah.
Yeah.
Okay, I thank you both very much. And I'm going to say the same thing I said to other people in this seat. On behalf of the committee, we extend our gratitude for all you and your staff to serve Vermonters. So thank you.
Thank you for the work you're doing as well, and for the invitation. Thank you. Feel free to reach out.
So we are done until 1.